Hello, everyone, and welcome back to the Born to Heal podcast. I'm your host, Dr. Katie Deming. And today I am doing a solo episode on breast cancer and hormones. And I want to start the episode by clearing up a misconception that many people have, is that if your tumor has estrogen receptors, that means that your cancer is estrogen-driven. And women get really afraid. They're like, oh, my cancer is estrogen driven. And so then I have to be afraid of the fact that my body makes estrogen. And I just want to say that all it means if you have estrogen positive breast cancer is that your breast cancer cells have estrogen receptors on them. And the reason why we test that is because we have medications that can block it. If we didn't have medications that could block estrogen receptors, I don't know that we would be testing that. So I want to give a little bit of the biology of breast cells and then talk about breast cancer cells and estrogen receptors. But I think it's important to understand the normal breast physiology in order to understand how to think about estrogen receptors on breast cancer cells. So normal breast cells have estrogen receptors on them. They also have progesterone receptors on them. And the reason why is because breast cells are designed to grow when levels of estrogen are higher. And there are certain times in our certain times in our life where estrogen levels are higher. And those times are during adolescence or puberty, during pregnancy, and also during breastfeeding. And basically, because breast cells have receptors on the outside for estrogen, it means that when estrogen levels rise, estrogen then binds to those receptors on those cells and sends a signal to tell the breast cells to grow. And this is just normal breast physiology. This is not related to breast cancer. So every cell in our body has specific receptors for molecules or hormones that they are sensitive to, which means they are going to do specific things when those molecules or hormones are around. And breast cells are designed to grow during adolescence, during pregnancy, and during breastfeeding. So they have estrogen receptors on the outside of them. And you can think of these receptors as like little hands on the outside of the cells, that when estrogen levels rise and the estrogen is present, it binds to those receptors and then sends a signal into that cell telling it to divide and grow. That is normal breast physiology. Now, with breast cancer, we check to see if those breast cells have estrogen receptors. And if they do, it's actually a good thing. And this is the big thing that I want people to take away from this, why I don't want people to be afraid if your breast cancer is estrogen positive. And it's a good thing because if your breast cancer cells have estrogen receptors, it means that those cells have not changed so much away from the normal cell that they've lost all the features of a normal breast cell. The most aggressive types of breast cancer have lost all of the receptors and lost all of the normal features of a breast cell. And that's why you'll hear people say a triple negative is a very aggressive type of breast cancer. It's because it's changed so much from the normal breast cell that it's lost all those receptors. And I also don't want people who are triple negative now to freak out and be like, oh my gosh, this means that, this is super aggressive. And that's the narrative that you're going to hear in Western medicine. And I'll do a separate episode, or maybe at the end of this episode, I'll have some time to talk about the way that I think about that. Actually, I will talk about how I think about these different receptor types of breast cancer. But basically, having those estrogen receptors actually suggests that your breast cancer is less aggressive because it still has the features of a normal breast cell. And then the other reason why in conventional Western oncology, they consider it a positive thing to have those estrogen receptors, is that then you have medications that could potentially either lower levels of estrogen in the body or block those receptors at the receptor site. And so I want to talk about those two options just so that you know what the different treatment options are that affect the estrogen receptor. But this is why having estrogen-positive breast cancer is considered favorable, is because the breast cancer tends to be less aggressive, still has a lot of the features of a normal breast cell, and then you have some treatment options that are less toxic than traditional chemotherapy. Okay, so that's the piece that I want people to understand in terms of the physiology of the normal breast cell, and then looking at the physiology of the breast cancer cells. Now, when your doctor talks to you about anti-estrogen, the type of anti-estrogen that they may recommend to you is different depending on your age. And there are different types of anti-estrogens. I'm not going to go into all of them, but I'm going to give you some of the classes so that you can understand the difference of these. Before you go through menopause, the anti-estrogen that is most likely going to be recommended is tamoxifen, or if they suppress your ovaries, then they may offer something else, but we're going to get to that next. So I just want you to hear this first, and then we'll get to talking about aromatase inhibitors. But tamoxifen blocks the estrogen receptor at the receptor site. So you can think of it like this. If you are premenopausal and tamoxifen is recommended, or even, I guess, in the postmenopausal state, the idea is that the tamoxifen when you take the tamoxifen, it would bind to that estrogen receptor, and then it would basically block the estrogen in your body from attaching to that receptor. And what the tamoxifen does, instead of stimulating growth, which the estrogen does, it basically shuts that down and it doesn't allow it to do anything. It just sits there. Except on certain cells in the body, tamoxifen has a proestrogen effect, and that is on the uterus. So on the cells in the uterus, tamoxifen is actually proestrogen, and that's why there is a risk of causing endometrial cancer with tamoxifen. That risk is low. It's about 1%, but there is a risk of that because it has a proestrogen effect on the uterus. But that's the way that tamoxifen works. And then the other risks associated with tamoxifen are blood clots. So tamoxifen can have the risk of increasing your risk of developing blood clots. And so anyone who has a history of that, they will likely not recommend tamoxifen. The other class of anti-estrogen medications are something called aromatase inhibitors. And these are used after menopause. So tamoxifen basically is given usually before you go through menopause. And I'll talk about the caveats of when it might not be when I talk about the postmenopausal state. But basically, before you go through menopause, your ovaries are still producing estrogen. And so you've got estrogen circulating in the body, and tamoxifen is used to block that estrogen from binding and sending the signal to the breast cancer cells to grow. And that's the mechanism. Now, after menopause, your ovaries are not producing estrogen. And so most people ask, well, where's the estrogen coming from after menopause? And we produce estrogen in the fat on our body. So all of us do this. So after we go through menopause and the ovaries stop producing estrogen, we are still making estrogen in our fat. And aromatase inhibitors, that's like Arimidex, letrozole, some of these other drugs, they basically block the production of estrogen in the fat because you no longer are worried about production of estrogen from the ovaries. it's coming from your fat. And so if you can block that production, you don't need to give something that's going to block it at the receptor. You can basically lower the levels of estrogen in the body by using an aromatase inhibitor. And the data shows that aromatase inhibitors are more effective than tamoxifen in postmenopausal women. And in premenopausal women, there's data that suggests that if you could suppress the ovaries and use an aromatase inhibitor instead of tamoxifen, that may be preferential. And so you may hear this from your doctor if you're premenopausal. They might start with tamoxifen and then suppress your ovaries either through an injection or removing the ovaries and then use an aromatase inhibitor. But the whole idea is that you can't use an aromatase inhibitor unless you have induced menopause. So these are some of the options that you're going to hear. There are a lot of side effects associated with just even taking any kind of anti-estrogen, but then especially for the young women of suppressing the ovaries and doing an aromatase inhibitor on top of that. And so the side effects associated with, we talked about tamoxifen, so the complications associated with tamoxifen mainly, I'm not going through everything, but the big ones are blood clots and endometrial cancer. Those are the two big risks associated with those. They're still small, they're in the single digits, but the risks associated with aromatase inhibitors are bone loss, so decreased bone density. And this is why your doctor will always check a bone scan, not a bone scan, but a bone density scan before you start an aromatase inhibitor so that they can see what your baseline bone density is before starting it, and then they can monitor it to see if there's been bone loss. So that is one of the main long-term risks associated with aromatase inhibitors. The other thing associated with aromatase inhibitor is that they can cause joint pain. And that's something that many women, it can be debilitating to have the joint pain. Okay, so those are kind of things that are specific to aromatase inhibitors. And if you look at the side effects, these are kind of the symptoms that you might experience on these medications. There are a lot of them that are common between the two. So hot flashes, weight gain, mood changes, difficulty sleeping. Hang on, Marvin, I'm wondering if there's a way for me to pause. I don't see it here. Hang on, I'm just going to pull something up. So some of the other ones that are maybe less common that people can have are nausea, headaches. Those are definitely lower on the risk. I would say the main ones for both tamoxifen and aromatase inhibitors are the mood changes, the hot flashes, weight gain. Vaginal dryness is also one that you would experience on both of them. So kind of think of it like anything that you would experience during menopause, those things will be exacerbated or induced through taking an anti-estrogen medication. And I think one of the important things to think about with this is what is the benefit, and then thinking about those risks. Now, in general, anti-estrogens reduce the risk of recurrence by a relative risk of recurrence by 50%. So let me just give an example. So say you've had a lumpectomy and radiation for an early stage breast cancer, and your risk of recurrence is, let's just say 10%. By adding an anti-estrogen, you're reducing that risk by 50%, but it's a relative risk reduction. So it's from 10% down to 5%. And that's an absolute risk reduction of 5%. So these drugs, when they're offered, many women have already had, surgery and radiation, and the relative risk reduction is significant, 50%, but the absolute risk reduction is only about 5%. And the other thing to note is that many women do not end up taking these medications as prescribed because their quality of life is significantly affected by this. And a lot of the studies have shown that only about 60% of women take these medications as prescribed because they don't tolerate them. And so that's something just to note, is that when your doctor talks about this, is a lot of women don't tolerate these medications because it's a big quality of life factor if you're moody and you can't sleep and you're gaining weight and just not feeling good. So those are things to like keep in mind when you're thinking about this. And the other thing is that, and this is going to get to the bigger picture of like all the different subtypes of, let's just with breast cancer. So thinking about triple negative or HER2 positive or estrogen receptor positive, these different types of breast cancers, the reason why we test these different receptors is to direct treatment. If we didn't have these treatments, these receptors may not be tested, because if we didn't have something to treat them with, there would have been no incentive to test these necessarily. And so you have to remember that. Like, I have a lot of people who come and talk to me and they're like, if you're doing more natural treatments, if you're really looking at a holistic approach of treating cancer naturally, they're like, oh, well, how would you treat it if it's triple negative or HER2 positive? But the truth is that these receptors and this whole idea of classifying cancers, much of it is driven by the Western oncology treatment options. And if you zoom out and are looking in the way that I'm looking at things now, so I was in that world for a very long time. Like I would, these are the talks that I had every day with people. I would be doing the radiation portion, but then they may not understand the anti-estrogen that their medical oncologist was recommending. So I would talk about this all the time. But now that I'm seeing, these treatments that we do, all of them, like surgery, chemo, radiation, anti-estrogen, none of them really deal with the underlying problem. I'm zoomed out and looking at, okay, why did you get sick in the first place? Like, what are the underlying causes? What are the things in your life that we need to change? And I talk about this in my guide, the 3 things you need to know about cancer, is that cancer is not caused by one thing. And unless you have even if you have a genetic condition, it's not just caused by that genetic condition, because not everyone with a BRCA mutation gets breast cancer. It also is influenced by your lifestyle. And this is the whole idea of epigenetics, is that you can have a gene mutation and it's not, you don't see that as a physical manifestation of disease unless the lifestyle is also contributing to that. So even with people who have genetic mutations, it's not like a done deal that means you get cancer. Your lifestyle plays a huge role in the expression of that gene mutation in terms of developing disease. But so cancer is not caused by one thing. It's really related to our modern lifestyle. And there's so many things that we need to change. And that's what I say all the time to my clients, is like, you have to change the way that you're living to change the underlying problem that led to disease in the first place. And so when I'm treating someone now, and I'm not treating, but when I'm coaching people on how to help them heal in a natural way, I don't care whether it's a triple negative or estrogen receptor positive or HER2 positive, because the underlying condition that caused you to develop this cancer has nothing to do with those receptors. Those receptors have to do with the treatments that are available from a Western perspective that don't actually address the underlying problem. And so it's all of the things. It's your diet. It's the supplements. It's your water. It's emotional trauma. It's stress and managing your emotions, ongoing. It's what's programmed into your subconscious mind. It's your alignment. Are you living a life that's true to yourself? All of those things are common for all of us. And this is not even just if you have breast cancer. This is if you don't want to get cancer. If you don't want to get all of the diseases that we are seeing skyrocketing, these are the things that you need to change. And so I really wanted to talk about, number one, just this idea women are now afraid of their own bodies because they think, oh my goodness, my body makes estrogen, so that's a problem. No, our bodies need estrogen for our bone health, for our cardiovascular health, for, to feel good, to sleep, all of these things. Of course, like the natural progression as we get older, menopause is a natural process, and that shifts for women. And you experience menopausal symptoms going through those changes, but also many women are struggling with menopause today. And a lot of that is related to our lifestyle. Again, we're eating the wrong foods. We're exposed to environmental toxins. All of these things are causing hormonal dysregulation. And so if we can start to get that right by eliminating the toxins in our life through the products that we use, through eating clean, and then eating the right foods, you can start to shift that without using any medications. And I think this is one thing that I've said on the episode where I talked about, what I learned in my first year of practice, but my approach is not to address things with more chemicals. I think we are in the position that we are in because of chemicals, because of the way that we're living. And so it's like Einstein said, you can't solve a problem at the same level that it was created. And we have this idea that we just need to, test all these things and then throw all these chemicals at it. But the truth is that if you can help the body detoxify itself and really clean itself out and learn how to take care of yourself in the way that your body was designed, you don't have to use chemicals for these things. And that is, now my practice is doing more of this holistic approach and really helping your body do what it knows how to do, right? And it's not an accident that this podcast is titled Born to Heal. And I titled it way before I left Western medicine. So I started this podcast when I was still practicing radiation oncology. But it's like that is really the foundation. We are born. Our bodies are designed to do this. Our bodies are designed to heal. But you need to have a plan and you need to know how to do this. But getting caught up in these subtypes and number one, being afraid of your body if you have an estrogen receptor positive breast cancer, you don't have to be afraid of your body. And in fact, maybe that's a good thing, having those estrogen receptors, because it suggests that the cancer is not as aggressive, right? So I want people to get out of the fear and start to have the information that can empower them to understand what these things mean and how to interpret it. And then the other piece is like the flip side of that is I don't want women who have triple negative breast cancer to be afraid, oh no, my cancer is so aggressive that there's nothing that I can do. I have to rush into treatment. I have to do all of these things. And so it's a game. To be honest, I'm becoming so disillusioned with the way that I was trained and the information that I learned, because I really believe that we've been taught incorrectly about all of this, because it's an industry and it's designed to sell medications. And if you know what this all means and how to address the underlying problem, maybe you don't need those medications. So let's address, because the other thing is women come to me and they say, well, if I don't do this, my doctor says it's going to come back. And actually, I just had this happen the other day where an oncologist said to one of my clients, she was considering not doing anti-estrogen therapy. And the risk of recurrence was, let's just say I think it was 15% in this particular setting. And the anti-estrogen was going to reduce that by half. So from 15 down to 7.5% risk of recurrence. And the woman was, not sure. And she said, I don't know that I want to do this. And the oncologist said to her, you're a mom. You have 4 kids. Don't you want to live for your children? And number one, if you have a doctor who says this to you, I would leave that office. That is not okay. Because if you take those numbers and you flip them around, even if you just use their model, that means 85% chance that you do nothing else and this cancer's not coming back and you're going to live a normal life. And then by adding the anti-estrogen, you're going to increase that from 85% to 92.5%, right? But you're buying a lot of side effects with those medications. And to say to someone, don't you love your children? Don't you want to be around for your children? When you understand those numbers, it's like, yes, of course. I mean, it's just a ridiculous statement in the first place, but it's like, it's a 7.5% absolute, percentage increase by doing this medication. But then, but meanwhile, I'm going to be angry at my children because I've got moodiness and I can't sleep and I'm going to gain weight and I have bone loss and you're going to suppress my ovaries. And it just, to me, some of these conversations are really upsetting now that I'm hearing them on the other side. And so when you hear those numbers, one of the ways that you can flip around and see, okay, how am I going to do if I don't do them is like without, and this is assuming you're not doing any of the things that I just talked about from a lifestyle perspective. But so say it was an 85% chance that it's not coming back. That's pretty good, and it's when you understand those numbers, it starts to help you make better decisions about your body. But those numbers do not assume any other changes. And if you're listening to my podcast, I know you guys are doing other things because you're learning so many other things to do. So unfortunately, we don't have the data. And that's the thing that is frustrating, but I think also something that you need to get comfortable with. We're not going to have data on, what the percentage is that is going to change with changing your diet, with doing emotional work, with improving your water, with detoxifying your body, because there is just no money in doing large scale studies. These studies cost millions of dollars to do. And the reason why the pharmaceutical companies do the studies is because they're going to make billions of dollars off these medications. So you have to understand that those doctors, if you said, well, what if I change my diet? What if I do, emotional? They would have no idea about emotional work. They'd probably think that you're crazy if you said that, but you can send them to my podcast. But they are not going to know what the numbers are going to be with these other items. And I think this is one of the big things that's hard to say. But even if you just said, okay, well, I'm comfortable with an 85%, disease-free survival, that the 85% chance I'm going to live in it, everything's going to be fine. That's without doing anything else. But if you do these other things, then to be honest, I think you're going to be in a better place because you're going to be dealing with the underlying problem that led to the cancer in the first place. And so my big takeaway is I want you to not be scared by your doctors. And I don't think the doctors want to scare you. I actually think the doctors are trapped. And I don't know if you know this, that the suicide rate among physicians is twice that of the normal population. It is very high. Doctors are trapped in a system. Many of them know something's wrong. They just can't get enough distance to see, and they've just been trained in this way. And so you have to think about your doctor as someone who has been trained in a very specific system without any of this other information about how the body works in terms of healing, and also what is the crisis that we are experiencing as a population. And so instead of going into the office thinking, oh, these people are gods and they know everything and they're the experts in this, they are experts in chemotherapy, and, giving anti-estrogen, these specific targeted drugs or radiation or surgery. That is what they are experts in. But actually why we are getting sick and what is the underlying cause of why you have this in the first place, they are not experts. And I will tell you, just because I was one of them, and I know many of them, and I know that they are not intentionally doing harm, they are trapped by the limitations of the system. And so for you, take the information, get the numbers. I think that's the most important thing. When you go in to see a doctor, you can get the numbers. Okay, like what is my risk of recurrence without doing the anti-estrogen, or if it's chemotherapy, whatever treatment, and what is my risk with having it, so you can understand the risk benefit, like the statistics without and then with that treatment. And then you want a full list of the potential side effects, which are basically like symptoms that can happen from the treatments that don't happen in everyone, but if they happen, they basically can alter your kind of quality of life. And then what are the potential long-term complications that can happen as a result of that treatment? Those are the things that you want to understand. And I wouldn't make a decision in that appointment. I would take all of that information. I would go home. I would talk with someone who you trust, who's grounded, who can help you think through this, because there's a lot of emotional strings that are pulled in all this. Well, don't you want to live? Don't you want to be here for your kids? Or you're not thinking about everyone else? This is not just you. This is, your family. And all of those things are not good for making grounded decisions. You want to get out of that. And so if you have family members who are also saying those things to you, you need to find other people to talk to, just so that you can really black and white understand the numbers, so that you can really understand what those mean. You can understand the risks and side effects so that you are well informed before you ever consent to taking any kind of treatment. And then think about all of the other things that you can be doing and understanding you're not going to get those same numbers with the dealing with the root cause of the cancer and doing all these lifestyle changes, but those are going to have an impact. And I can tell you, just because I'm watching that, I'm seeing that doing all of these other things really make a difference. And I wish I could say these are the numbers specifically, but I also am a realist to say this is the world that we live in. And the world that we live in is not incentivized by teaching people or, studying the benefits of diet in some large randomized trial for breast cancer so that you're going to get great statistics. You're just not going to get that. But knowing that if you don't do those conventional therapies, that you can do these other things to really change the biology in your body of what's happening and why you got sick in the first place. And even if you do those therapies, you want to do these other things because those therapies don't address the underlying problem. Those therapies are just dealing with, cancer cells and stopping them. And then one other thing to know about anti-estrogen that is super important is that anti-estrogen is something called a cytostatic drug rather than cytotoxic. Chemotherapy is cytotoxic, means it kills the cancer cells. Anti-estrogen just puts the cells to sleep. So that's why when women come off the anti-estrogen 5 years, 10 years down the road, you can have a recurrence. These drugs are not eliminating basically the cancer cells. They're suppressing them. And so you can have these later recurrences. And that is super important to know because they make you think, oh, this is eliminating. It's like, no, it's basically stopping that growth during the time that you're on the medication. And then when you go off it, those cells are still there. And then if there's estrogen, then, the idea is that then that can cause a recurrence after you come off them. And that's what we see too. I want you to understand all this information, not because I'm absolutely anti-estrogen therapy, but I want you to understand this so that you're not made to feel like you have to do something. You are going to collect information so that you can make a decision grounded in factual information and then decide what to do based on your values and what is best for you. And if you have a doctor who tries to push you into doing these things and using some of the language that I said that's very manipulative, find another doctor. Because this is not as cut and dry as they will make it sound, like you have to do this and that this is the only way for you to be alive for your children or whatever it is. So I hope this is helpful, and I would love it if you guys have other questions. So this episode really came from the questions that we got on Instagram. I had a ton of questions about anti-estrogen. So feel free to send us DMs on Instagram with your questions, and I will do my best to answer them. I hope you have a wonderful rest of your week, and I will see you next week. Take care. Thank you for joining me on Born to Heal. It's been a privilege to share this time with you, and I hope that today's episode has offered you valuable insights on your journey toward optimal health. Please consider subscribing, sharing this podcast with your friends, and leaving us a review. To learn more about how you can work with me, please visit katiedeming.com. You can find additional resources in the episode show notes linked below, and remember to join us next week as we continue to explore more holistic approaches to healing. Until then, this is Dr. Katie Deming, reminding you that just like me, you were born to heal.